Hi, my name is Stephen Black. I am a consultant vascular surgeon at Guy's and St Thomas's Hospital in London and a professor of venous surgery at King's College London. Well, venous outflow obstruction has struggled for years with options as to how to treat them. And we have now advanced and developed a number of venous stents and other options that help patients, but this is still really at the infancy of being able to treat these patients effectively with the first generation of dedicated venous stents. So if we look at what the unmet needs are, it's to improve the outcomes for patients who've got acute DVT and chronic post-thrombotic syndrome and try and make those treatments more durable and more effective. The Abre stent is a self-expanding nitinol stent which has an open cell design. It comes in a triaxial deployment system that allows it to be accurately deployed into the venous space, and it's really been developed to meet the needs of the venous anatomy as opposed to simply being an iteration on an arterial stent. The unique feature of Abre over some of the other stents that are available on the market is that the strength of the stent is maintained through the size range, so that if you choose a 12, 14, or 16, or 18, the strength of the stent in common terms is going to be the same. So in other words, the radial force, the radial resistive force, the chronic outward force, and crush resistance are all going to be maintained across the size range. So the Abre study was a prospective, multi-center, non-randomized study designed as a device exemption study for the FDA. We looked at 200 patients selected from 24 centers both in the US and Europe. And those patients were clearly divided into three distinct subcategories, being non-thrombotic iliac vein lesions, acute DVT, and chronic post-thrombotic syndrome. The key point about Abre study was that 44% of those patients were classed as complex, as they required stent extension below the common femoral, but below the inguinal ligament to the common femoral vein, which typically indicates that there is quite extensive disease. So this is a challenging patient population group. Well, I think the 36-month data really supports the outcome that treating these patients gives you sustained clinical benefits in terms of improvements in clinical severity scores and sustained improvement in quality of life, with all the patients improving dramatically in the first 6 months, and this being maintained through 36 months with no significant drop off. We also noticed that patency rates, particularly in the NIVL population, were well maintained. There was still a good patency in the chronic post-thrombotic and acute DVT groups out to 36 months, with the overall patency of the whole study group being 81%. I think the take-home message is that venous stenting works. I think we've seen now this in amongst a number of other studies that have been IDE studies, but also literature that has now been published by centers that have published single-center cohort studies, that we do see that you can get sustained clinical outcomes from patients using venous stents, and that the stents themselves are robust. There were no stent fractures out to 36 months in Abre, and there were no migrations, which means that if the stent is used properly within the indications for use, it is going to work and it's going to be sustained. I think we still really need the randomized trial evidence that would support this practice, and I would really encourage those, particularly in the United States, to continue to support the C-TRACK study. And in Europe, we're launching the BEST PTS study, which will hopefully add to the weight of evidence that venous stenting or intervention for chronic iliac outflow obstruction is worthwhile. I could add to next steps is that we can clearly see differentiation between the different patient groups. NIVL patients do very well, we know that. Acute DVT and post-thrombotic patients have a higher drop-off in patency over time, so I think we need to work at increasing that primary patency rates across these two more complex groups. We have to understand what drives in-stent stenosis and come up with mechanisms to manage that. So we know we get good patency, but for that cohort of patients who lose patency out at 36 months, there are very poor solutions for managing them. So I think that challenge is really something that all the studies have been similarly showing. There really isn't a differentiation between the different studies that have been published, and that remains a challenge that we need to get to grips with.